In this unedited video, I'm going to show my technique in quick chop. It starts with regularly the incision. I work temporarily, doing a temporary clear cornea incision with 2 paracenteses. This patient had previously done pterygium excision. Now finishing the capsular access by following the rules to get a continuous regular access, working in deep chamber and holding near the tearing edge, with the flap always brought to the center. Next step is hydrostaction, where I get some viscoelastic out first and then go to the equator, injecting a wave of fluid, making sure it passes to the opposite side. Once this is done, we start the technique of quick chop. Here you have good exposure of the tip. I use Neuhann Chopper, which is used for vertical splitting, or called nuclear splitter. And now just shaving the cortex and then embedding into the nucleus with low power, high vacuum, and you use the nucleus splitter to split the nucleus along the normal cleavage lines. This makes it very easy. What you need to do is just impale the nucleus with little ultrasound. That's why we need good exposure just to embed into the nucleus, and with the nucleus splitter you can split the nucleus very easily and then aspirate it. And with, even if it's a large part of a nucleus, you can re-split it and chop it again while it is held in the tip of the phaco. You can see splitting, impaling. We use high vacuum, 450 millimeters of mercury, very low power, 20%, even less, 20 to 30%. And you just need it to start embedding the tip into the nucleus. And once you have it on the tip, you can even split it into smaller and smaller pieces. In this way, you need less and less power, which saves a lot to the cornea. And you can see the last bit is removed with almost no epinucleus present. Once you do good hydrosection, you always get the epinucleus out with the nucleus. I get out with the phaco tip, injecting viscoelastic. And this is, I think, an important step while exchanging hands between instruments to get the irrigation aspiration. Having the anterior chamber filled with viscoelastic avoids forward movement of the vitreous. Now, bimanual irrigation aspiration is a very useful technique, as you can get any part of the bag to get the cortex. It's very simple, and you always direct the irrigation into the capsular bag, inflating the bag, facilitating aspiration of the cortex. Once I finish this, you can notice there are cells and some fibers, filaments actually, on the posterior capsule. I don't bother to remove them with the irrigation aspiration. I just use a 27 gauge cannula to wash them off the posterior capsule. This is a simple, reproducible, very useful way to clean the posterior capsule to the last bit of epithelial cells. This is followed by viscoelastic injection, and then the IOL. Being a one-piece lens, hydrophilic acrylic, I need to enlarge the incision into 2.4 millimeters, and with the cannula engaged in the paracentesis, it helps as counter pressure while injecting the lens. And the second value is that it can push the lens directly into the capsular bag, avoiding the need to rotate the lens or use more instruments into the eye. Immediately, irrigation aspiration of the viscoelastic is done, whether in front or behind the intraocular lens. Last step is hydration of the paracentesis and the main wound, followed by intracameral injection of Vigamox. Actually, I injected intracapsular into the capsular bag, and this is very useful in preventing endophthalmitis. Hydration, as you can see, followed by intracapsular Vigamox injection. And that's it. Thank you for watching.